Hello, welcome everybody to Oxygen Therapy and Critical Care, the case-based series. Before we begin, we do have a couple of quick reminders. For one, we will be using the chat function for question and answer today. To access this, the button is at the bottom of your screen. So if you have questions or comments throughout the presentation, please share them using the chat box and feel free to introduce yourself. If you're having any IT issues, so for instance, issues with your sound or viewing the presentation on the screen, send us a message through chat or the WhatsApp group, and we will be pleased to support you. And finally, this session is being recorded and your attendance is consent to being recorded, so thank you. So today we are excited to be on session 9, Pediatric Considerations for Oxygen and Critical Care. The date is February 4th, 2022, and as usual, we have our wonderful panelists here to teach us the content and take us through a case-based lesson. So we have Dr. Rachael from Epiglottitis County Hospital, Dr. Anthony from KUTRRH, and Dr. Eunice from Tigoni Hospital, and all in Kenya. So with that, I will pass it on to Dr. Rachael to get us started.
Thank you, Anana. Good evening, everyone. So once again, welcome to today's session, session 9. Here we're discussing about considerations of oxygen in the pediatric group of patients. So should you have a question, you can ask it in the chat box or you can raise your hands. But we're going to try and make it as interactive and as simple as possible. Thank you once again for joining in, and we can start. We can have the presentation. So today we have a 6-year-old male who presents. Oh, what happened to my laptop? Sorry, what has happened? Okay. So we have a 6-year-old male who presents with wheezing and increased work of breathing. So can go down. So in this session, we want to understand what are oxygen requirements in the pediatric patient, what causes hypoxemia in pediatric patients. So to go to our practice change objectives, this is just some information on WHO, which I'll not concentrate on. So in our practice change objectives today is to know the various oxygen supply options for various pediatric healthcare settings, know the various oxygen delivery devices available for pediatric patients, recognize safe SpO2 levels or goals for various pediatric patients and conditions, understand and treat pathophysiologic conditions leading to hypoxemia in pediatric patients, recognize hypoxemia during the clinical exam of a pediatric patient, understand diagnostic considerations for pediatric patients with hypoxemia, appropriately prescribe oxygen therapy for pediatric patients, implement appropriate therapeutic options for pediatric patients with hypoxemia. So we have this case. So we have a 6-year-old male with no significant past medical history. He presents to the emergency department with wheezing and increased work of breathing. His symptoms started 12 hours ago. He has been less active for the past 24 hours by his mother's account. His mother also describes 5 days of fever with temperatures of 39.3 degrees Celsius. He had a respiratory viral panel and rapid COVID test was done and it was negative. At the time of his respiratory panel, this means examination, the SARS which was done 2 days ago, he had no respiratory symptoms. However, his mother does report that his eyes were red and, his eyes were red and he has redness and swelling of his hands and palms. He also reports that today his eyes seem swollen. The patient's aunt lives in the same house and had COVID-19 3 weeks ago, but her only symptom was anosmia, loss of smell. So the birth history, this patient was born at 32 weeks by vaginal delivery, secondary to severe preeclampsia, 4 weeks in NICU for feeding and growing, No CPAP or mechanical ventilation was done. No past medical history. Past surgical, had an appendicectomy done in 2019. Lives with his family, his parents, grandparents, paternal aunt and uncle. And remember, the aunt had been recently diagnosed with COVID-19. He's up to date with the vaccinations, not on any medication, and has no allergies. So we're going to first do a recap on oxygen supply. This is something that we had discussed earlier on in the earlier sessions, but this is just a recap. So we want to know what oxygen supply options are there in various healthcare settings. We all know that in most of our facilities, we have different types of oxygen sources for the medical air, for the medical grade oxygen. So we could have concentrators, we could have cylinders, we could have liquid oxygen, and also oxygen plants. So every facility, depending on their capabilities, have, most of them in our setup, especially the government hospitals, usually rely on both oxygen concentrators and oxygen cylinders. So those are the 4 sources of oxygen. So the next thing is, which of the following oxygen sources are available at your facility? I'll not ask you to answer this because we all are coming from the same kind of healthcare facilities, whereby very minimal people or very minimal facilities have oxygen plants, and we all rely mostly on oxygen concentrators and cylinders. But you'll have in the private sectors, or even in like Kenyatta National Hospital. Kenyatta National Hospital has liquid oxygen tanks, and KURH has oxygen plants, and also various hospitals are in the process of getting oxygen plants. Alana, you could go down. So in this patient, the patient was had a fever, 39.3, heart rate was 135, that's the blood pressure, respiratory rate was slightly, it was 35, and was saturating at 88% on room air. So clearly this is a patient who requires oxygen supply because of the amount of oxygen that he's getting. On room air, he's saturating at 88%. We always want to aim for anything above 92% and above of oxygen. So supplementation needs to be done in such a patient. So for oxygen delivery, this is also a refresher. You could go down. So this we can use mostly in the pediatric patients. And even in other adult patients, but the device is the same. So we have nasal prongs, whereby you want to put an amount of children, you can have to do 6. You can beat up to 6. And nasal prongs, as discussed earlier, the amount of fraction of inspired oxygen that you get is 45. You have minimal PEEP that is delivered. Humidification is not required because now the humidification is usually from the flow meter that you connect onto the cylinder. So you might require the humidification, but most of the time, facilities can also offer it without humidification. Risk for hypercapnia is not there. Airway obstruction, no, and so the equipment required is usually nasal prongs. Then the other thing, you have nasal catheter. In neonates, you'll put a flow rate of 0.5. In infants, you put a flow rate of 1. Here, the FiO2 that is inspired is 50%. Then you have the nasopharyngeal catheter, almost the same amount of flow that is put in the patient. And here the FiO2 is 55. There are options of even having an oxygen mask or even an oxygen mask with a rebreather for the older children. The ones who will be able to handle the oxygen mask with the rebreather. We can go. Head box is not a common thing in practice. So this patient was given oxygen via nasal cannula at 4 liters per minute, and we can see that at least his saturation has moved from 88 to 92. So I won't dwell much on that in case, I hope this, if I'm going too fast, you can just raise your hand or put the question on the chat box, just that it's a recap from the previous sessions. So for pulse oximetry, So what are our goals here is to recognize safe SpO2 goals for various pediatric patients and questions. So I want us to answer this question: which one of the following statements are incorrect regarding oxygen therapy in neonates? So you have A, all infants below 32 weeks gestation or weighing 1.25 kgs and who receive oxygen therapy should be screened for retinopathy of prematurity at 4 to 6 old. Then there's B, newborn infants requiring oxygen therapy should have SpO2 targets of between 85 to 95%. Apnea leads to bradycardia, which further reduces oxygen delivery. Neonatal ventilatory support should be administered with bag mask ventilation and FiO2 of 100%. So I'll give a minute to that, and we can try and answer to see which one of the following is incorrect.
Dr. Rachael, should we end the poll?
Oh yes, we can end it. So majority have said D, which is true. It's an incorrect statement. The neonates, you're not able to, you cannot give the bag mask ventilation. Basically what it means is you're trying to bag this patient with 100% of oxygen. It's not a way of supplementing the oxygen that they require. So for infants who are less than 32 weeks gestation, we know that oxygen is oxygen is a drug and can be toxic. So it usually affects the membranes and can cause retinopathy. So it's good to screen these patients and check if patients who are premature, patients who are premature and got oxygen, did that oxygen cause some effects on the retina? Then the other one, the targets, it's for neonates, you also need, newborn infants, you need to have your targets between 88 to 95. You may not get 100% because remember these newborns, their lungs are still atelectatic because they were in the womb and there was so much fluid. So they still need to be able to push out the fluid from their lungs, and hence not all their lungs is participating in oxygenation. So getting 100% of oxygen is a bit impossible. 100% in your SpO2s is not possible, or it takes time. It's not immediate to get 100% on SpO2 reading for the newborns. Apnea leads to bradycardia. That's almost straightforward. And yeah, this when you're bradycardic, that means even your heart rate is low. What happens now is that oxygen delivery to the rest of the tissues is impaired. Thank you for attempting. You can go down. So true or false, where pulse oximetry is not available, oxygen should be given to all neonates who have cyanosis or a respiratory rate of more than 70 per minute, or who are too sick to feed. I can give half a minute to this as we try and answer that. The majority are saying true. Anyone else who has a different? Okay, I think we can end the poll. Yes, as long as the respiratory rate is that high, this means that the patient is not getting enough oxygen, or the tachypnic and the respiratory effort is really impaired. So you need to supplement that oxygen until you're able to supplement it as you look for the pulse oximetry. Don't wait for the pulse oximeter to come and give you a reading and then so that you give oxygen. You can use your clinical examination to see that this patient needs oxygen. Maybe they have cyanosis, central or peripheral cyanosis, so that will help. In children living at high altitudes, above 2,500 meters above sea level, the normal oxygen saturation is lower than those living at sea level, and the level of SpO2 such as 87 could be used as a threshold for giving oxygen. True or false? Can answer that as well. Lost the poll. Seems not to be there. Alana, are you able to show the poll? That question. What are the results?
Yes, the results are 81% true and 19% false.
Yes, the answer is true. People who are living in high altitude tend to have the normal oxygen saturation is lower than the others because the people living in high altitude will not have oxygen saturations of 100%. You might have them even having at 85 or 87. It's just like the mountain climbers. The oxygen saturation is usually lower, or the reading for the oxygen saturation is lower compared to the people who are living at sea level. The other question is, oxygen should always be given intermittently, such as every hour or two, and should not be administered continuously in order to conserve oxygen supplies. True or false? We have 20 more seconds to end the poll. Okay, poll ended. So yeah, the answer is false. If a patient needs oxygen, please give them oxygen. Don't give them intermittently. Give them oxygen until whatever disease state they have is corrected and the patient is able to now sustain or is able to have good oxygen delivery to the tissues. So we'll continue to the next part. So you have our patient remains tachypnic, the baby, remember, with nasal flaring, intercostal retractions, but slightly improved SpO2, stable at 92% on 4 liters of nasal prong. So what are differential diagnosis? These are differential. So this patient could either be having asthma, reactive airway disease, it could be a foreign body, bronchiolitis, bronchitis, COVID-19, pneumonia, upper respiratory infection, congestive heart failure, multiple system inflammatory syndrome in children, cystic fibrosis, mediastinal mass, tracheoesophageal fistula, primary ciliary dyskinesia, laryngomalacia, and gastroesophageal reflux diseases. So all these could be possible causes of the patient's condition. So in the pathophysiology, we want to understand and treat pathophysiologic conditions leading to hypoxemia in pediatric patients. So what are the 4 most common diseases that cause hypoxemia in neonates? So in neonates, the most common thing is you have birth asphyxia, could be related to prolonged delivery or prolonged second stage, or could be related to difficult extraction of the baby, and the baby has prolonged birth asphyxia. It could, in kids also, we have something we call respiratory distress syndrome that could cause hypoxemia. And there's also pneumonia. They could get pneumonia as well of the newborn, and transient tachypnea of the newborn as well could be a possibility for diseases causing hypoxemia. This is in neonates. In children, the diseases that could be common that are causing now the hypoxemia, especially in children, they could be septic, meningitis, could be pneumonia, anything that is going to affect the blood oxygen transport or exchange causes hypoxemia. So it could also be asthma in kids, bronchitis, bronchiolitis, and even sepsis. So those are some of the causes that can cause hypoxemia in children. So hypoxemia results from decreased oxygen saturation of hemoglobin in the arterial blood, and this can occur in 4 different ways. We have the low levels of alveolar oxygen. So basically, oxygen level getting to the lungs is low. You have impaired diffusion. Impaired diffusion could be an issue of if there's a clot or something that's blocking transport of blood into the alveolar or into the alveolar membrane to help in exchange of blood. Now you have hypoxemia setting in because now there's no that blood exchange, or there's no blood that is able to pick up the molecules of oxygen to transport to the tissues. Impaired oxygen binding to hemoglobin could be an issue of the alveolar capillary membrane. Maybe it's fibrotic, or there could be fluid around that membrane, and there's a VQ mismatch. Could go down. So list 2 etiologies leading to low levels of alveolar oxygen. I'll give a second to this for at least 2 or 3 attempts on the chat box. 2 etiologies leading to low levels of alveolar oxygen. Can have at least 2 or 3 attempts on the chat box. Try and make it interactive. Can give a minute to that attempt. Nobody wants to try? Oh, someone is saying COPDs. Yeah, that's true. High altitude obstruction, it could be a foreign body, asthma, ARDS, pneumonia. Yes, aspiration. Thank you for your attempts. So all those answers are correct. So those are some of the causes that can lead to low levels of alveolar oxygen, ARDS, asthma, obstruction, foreign body, and aspiration. Those ones can affect the amount of oxygen that's getting to the alveolar for exchange. What type of poisoning leads to ineffective binding of oxygen to hemoglobin? In what setting is this poisoning a risk? I'll give a minute for this for participants to try and attempt. Alisad says bronchiolitis. Yes, that's true for affecting the alveolar oxygen. Someone has written carbon monoxide poisoning, lead poisoning. No one else wants to try, but the answer, the most common of them, especially in yes, carbon monoxide poisoning, especially in a setting, the low resource setting, is usually carbon monoxide poisoning, because we have parents who cannot afford gas as their means of cooking, and they have now, they use charcoal, and they probably all are staying in a very small house. So this issue of now the charcoal is broken down to carbon monoxide, and there are these children, everyone is in one roomed house. So this carbon monoxide competes with oxygen for hemoglobin, and it's usually, it diffuses faster. So it usually binds faster compared to oxygen to the hemoglobin, and then displaces the hemoglobin, and you end up having low oxygen levels in your saturation. So hence, when you get these low oxygen levels, now you have effects of hypoxemia. You have a patient getting confused, you have a patient getting unconscious, and eventually can lead to death. So it's a very common thing in the low resource areas, where their mode of the fuel that they use for cooking is charcoal, or instead of gas. So list 4 causes of VQ mismatch common in pediatric patients. We can attempt this as well. I discussed this, I think, in session 6 or 5. I think it was session 5, about the VQ mismatch. So we could try it. Causes of VQ mismatch. Someone says RDS, respiratory distress syndrome. Anybody else wants to attempt? Continue keeping bringing in. Severe pneumonia. Asphyxia. So we're talking about anything that is going to affect ventilation and perfusion. So if it's something that's affecting perfusion, you're thinking of maybe a pulmonary embolism that's going to affect the perfusion, so you're not able to pick up the oxygen in the lung. If it's something to do with ventilation, you're thinking about what is happening in the lung: pneumonia, fibrosis of the lung, asthma, COPD, or bronchitis or bronchiolitis, something that's going to affect the caliber of the lung tissue. So all those conditions that you've all put are correct, and they usually cause VQ mismatch. You're also thinking about congestive heart failure. In congestive heart failure, the patient ends up having pulmonary edema. So with pulmonary edema, what happens is that the lung is now floating in fluid, and hence oxygenation is impaired. You have cystic fibrosis, so the lung parenchyma is also affected, and there's no, the patient is unable to have adequate oxygen transportation and exchange. Thank you for your attempts. We can continue. So our patient remains tachypnic and stable, nasal flaring and intercostal retractions. WBCs are 2,000, platelets are 110,000, CRP is high at 30, ESR is also high at 80. Now chest X-ray shows bilateral multifocal, ground glass, and consolidative airspace opacities, cardiomegaly, and bilateral pleural effusions. So at least now with this chest X-ray and some of this lab works, we're able to rule out now the other differentials, some of the differentials that we had. And now here the differentials that now we're left with, we have congestive heart failure, COVID-19, bronchiolitis, and bronchitis. So with further investigations, we're able now to rule out and narrow down to a diagnosis so that we're able to manage the patient appropriately. Okay, can go down. So I'll hand over this point to Dr. Ngatia to take us through the clinical examination. Dr. Ngatia, karibu.
Hello, everybody. So I'll take you through the next phase of the presentation. So basically, this part is mainly a recap of what we have already done above and also in the previous lectures. So the main objective of this part of the clinical is to recognize hypoxemia during clinical exam of pediatric patients, understand diagnostic considerations for pediatric patients with hypoxia. So we're going to watch a video below. So just try and look at it and capture as many signs as possible. Let's play the video.
So I looked up asthma and it said C, C.
There.
Well, it just says C medical code if you can't.
Okay. So just make a point to note, we're going to go, there's a question we are going to go through that has a listing of what we have just seen in this video. So maybe you can scroll down. So we have WHO oxygen therapy for children. So it has 2 strong recommendations. There are 2 questions that you have done up there. So these are the recommendations that the WHO provides. So the first recommendation is detection of hypoxemia. First is the use of a pulse oximeter to detect hypoxemia. So this will be able to guide you also is the level of what level is the patient saturating. Then you'll be able to know which modality to actually start the patient on, what oxygen therapy to actually start on. Then the second recommendation is, maybe you can scroll up. So the second recommendation is to use clinical signs. So in an area or a setup where maybe we can say we do not have a pulse oximeter, so there are those obvious clinical signs that you should not miss, like the ones that were there maybe in this baby, that you should not miss. And when you see some of these things, even if you do not have a pulse oximeter, you should be able to start oxygen in this child, in assumption that this child already has signs and symptoms that are corresponding to hypoxemia. So some of these things are central cyanosis. I know maybe you can say our children are dark, but actually when you get severe cyanosis, you can actually tell the children with central cyanosis. There is nasal flaring, inability to feed or drink when due to respiratory distress. There is grunting with every breath, depressed mental status. Like this child in the video, you are noticing the child was not alert, the child was lethargic and drowsy. So these children, once you get such a child in your department, you need to start supplementing oxygen. Also, in some situations and depending overall clinical conditions, children with the following less specific signs may need oxygen. When children have severe lower chest wall indrawing, when the respiratory rate is greater than 70 breaths per minute. That was in the question that you answered above, and most of you actually said this child needs oxygen. And also one of the signs you also look out for in severe distress, you'll notice that there is the head nodding in a child. That indicates a very severe distress. So these children, you should be able to supplement oxygen. So in summary, so these 2, when you have a pulse oximeter, use it. If you do not have, use the signs and symptoms of respiratory distress to guide you to supplement oxygen. Okay. Can you scroll? So, sorry. So what are the major challenges when examining pediatric patients for hypoxemia? What are the major challenges when examining a pediatric patient for hypoxemia? Maybe I can have a few answers in the chat box and see what challenges you face when you're examining a pediatric patient. Just give like a minute. Yes, someone says restlessness. True. We never see pediatric patients. What's your challenge when you're dealing with patients, especially pediatric patients? Irritability. True. Non-cooperative. True. Yes, some because of their status. True. Frequent movement. Yes. Thank you for your answers. So this is true. What you have all mentioned is true. When you're dealing with pediatric patients, some are very irritable. You cannot communicate with them. There's also, they may be uncooperative. Some have mentioned that the child may even be unconscious. So, and then there's also the factor of also the caregiver. The caregiver may also not be cooperative and may not aid you in being able to examine the child as well. So these are some of the challenges you face with a pediatric patient. So all the answers were correct. So when you scroll down, the case update. So for the vital signs, the temperature is 38.9, pulse rate of 133, respiratory rate of 30, blood pressure of 77/38, and SpO2 of 92%. So when you do physical examination, so pertinent, so the positives, we find that the weight of the child is 20 kilos. Generally, the child appears ill, drowsy, but arousable in moderate distress. The eyes, there is bilateral conjunctivitis, but no discharge or scleral, icterus, mild periorbital edema without erythema. Then for the nose, there is nasal flaring. For the mouth, it's tacky, mucous membrane, slightly swollen, strawberry red tongue. For the chest, we have a positive increased work of breathing with accessory muscle use and intercostal and suprasternal retraction. And when we auscultate the lungs, there is crackles at bilateral lung bases with intermittent wheezing and prolonged expiratory phase. There is no stridor or rubs, and there is good air movement. So in the cardiovascular system, PMI in the left, mid-axillary line, in the 6th intercostal space, there is tachycardia with a regular rhythm, normal heart sounds S1, S2, but there is an S3 gallop. There is no murmur, no rubs, 1 or 2 pluses in the extremities, with a slightly weaker femoral pulses. Capillary refill is at 3 seconds, slightly prolonged. For the abdomen, examination of the abdomen, the liver edge is palpable 4 centimeters below the costal margin, but scratchy test reveals a slightly enlarged liver of 9 centimeters. The extremities, we have non-pitting edema in the hands and in the feet with no cyanosis. Then the skin, there is pulmonary erythema bilaterally, no rashes, poor skin turgor with mild tenting. So this patient has, when you do this general exam, as you can see, this patient has presented with just initially you thought it was, you can see signs of respiratory distress, But when you do a thorough physical examination, you actually note this child has very many things that you can actually pick up from all the many systems. So it means this child does not only have one system that is failing this child. This child has many systems that are failing. So even this will, from our initial diagnosis, we had seen a possible diagnosis was pneumonia. We had said asthma and congestive heart failure. But from this, we can see we are going to add something extra after doing a thorough examination on the child. So at the end, we'll be able to see what is the diagnosis with this child. So let's continue. So which signs are emergency signs requiring immediate intervention or time critical care? So as we said, when you're dealing with pediatric patients, there are some things that you have to look out for, and you know which one should be immediate, dealt with right now, and is there something else maybe you can buy time as you're doing, like take time. So for emergency signs that you cannot miss, a child who is obstructed or there is absent breathing, so for this child you have to intervene definitely. Severe respiratory distress, a child with central cyanosis, signs of shock, which include cold hands, capillary refill of greater than 3 seconds, high heart rate with weak pulses, and low or unmeasurable blood pressure. So this is a child who is either in shock or in impending shock. So this child, you need to intervene immediately. A patient who is in coma or serious reduced level of consciousness, a child who's convulsing, signs of severe dehydration in a child with diarrhea, lethargy, sunken eyes, very slow return of skin after pinching, or any two of these above. So these are the emergency signs that you need to look out for in pediatrics. Then there's something called the priority signs. So there's an acronym that you use, 3T, PRs, and MOB. So these are pediatric patients who, when they present in the casualty, these are the things that will make them, as much as you may have many children in the casualty, there are some things that will take a child who has just come in and prioritize them to be seen by a clinician, or for you to intervene before the rest of the children, who, even if they came earlier. When you have a tiny infant, any sick infant than 2 months, temperature, child who is very febrile. Another T is trauma or other urgent surgical conditions, which can be intestinal obstruction. So those things, you have to prioritize those children. Patient who has severe color, history of poisoning, patient in severe pain, and also for the R's, respiratory distress, child who is restless, continuously irritable, or lethargic. Then a referral, a patient who has been referred from another facility. And when you see this child, and especially if you're going to a higher facility, that is a child who you need to intervene. Also, visible signs of malnutrition, like severe wasting, edema of both feet, burns, major burns. So the way you remember this, you said T's, TPR, and MOB. I think Dr. Rachael had already discussed this, and I've already alluded to this, the signs of hypoxemia. You can have when you have your saturation less than 90%, central cyanosis, nasal flaring, inability to drink or feed when it is due to respiratory distress, grunting, and depressed mental status. And then also some situations, we said lower chest wall indrawing, respirate greater than 70, and head nodding. So this one, signs of hypoxia, we said, this child, you see these things, you start oxygen, even if you do not have a pulse oximeter. Okay, go down. Let's go. Okay. So this is just illustrating a nurse checking for hypoxia. So how can providers distinguish between respiratory distress and respiratory failure? So there is a difference between the two. Distress at times, they're those things that you will first pick up on the patient. But when you go to failure, there will be obvious impairment, like the patient will not be able to perfuse well and oxygenate well. But there is a video, maybe we can click and they can watch the video, which can just give them a good explanation to it.
Recognizing Respiratory Distress and Failure by Dr. Monica Kleinman.
When we say respiratory distress, we're really referring to the use of compensatory mechanisms to maintain adequate oxygenation and ventilation when something, one of many things, is causing respiratory compromise. Typically, the compensation consists of an increase in the rate and work of breathing. That increase will increase minute ventilation, allowing the child to exhale more carbon dioxide when gas exchange is impaired. Signs of respiratory distress include retractions, sternal retractions, for instance, because of the flexible, compliant breastbone, as well as intercostal retractions. And this is an example of increased effort resulting in muscles exaggerating the spaces between the ribs or in the sternum. Use of accessory muscles, such as the strap muscles in the neck, nasal flaring, and grunting, an expiratory noise that's designed to apply some PEEP. Children in respiratory distress typically are anxious. This is an uncomfortable feeling, and with that stress, they oftentimes have tachycardia. These are some examples as well of signs of respiratory distress. The child who wants to sit upright and is unable to lie flat comfortably. The child in the left looks anxious, and the child in the right is demonstrating increased work of breathing. Respiratory failure, on the other hand, is at the other end of the spectrum and is defined by inadequate oxygenation and ventilation. Essentially occurs when compensatory mechanisms fail to maintain gas exchange. Interestingly, respiratory failure can occur without preceding respiratory distress, meaning it can happen when there is depression of respiratory effort, typically by something like a poisoning, which depresses mental status, or seizures, or severe weakness, leading to inadequate respiratory effort. Signs of respiratory failure when the compensatory mechanisms are no longer able to sustain gas exchange include desaturation or cyanosis despite supplemental oxygen, the appearance of increased effort leading to poor air entry. In other words, lots of work for very little gain. This may be characterized by a sound of gasping when the child inspires, head bobbing, which is an exaggerated form of accessory muscle use in which the head literally will bob as the muscles of the neck and shoulders are trying to participate in gas exchange. Seesaw or paradoxical respirations, where the abdomen and chest move in the opposite ways than they usually do. And sounds of severe obstruction, such as stridor. The hallmark of respiratory failure, to distinguish it from respiratory distress, is a change in mental status. When oxygen levels fall and carbon dioxide rises, this is a very stressful feeling and results in sympathetic stimulation and agitation. As carbon dioxide continues to rise, it has a sedating effect on the central nervous system, leading to a child who's lethargic, sleepy, or obtunded. The child who appears to have increased work of breathing, desaturation, and sleepiness or obtundation is one in whom you need to be very concerned has transitioned from respiratory distress to respiratory failure and may progress to respiratory arrest and cardiac arrest.
Okay, I think the video was very good. It's been able to just capture the things that we've been emphasizing over and over and over again. And I feel like it is good that we keep emphasizing this so that you don't forget, because that is the point at which you will go and intervene in this patient. So the next part, we're going to do therapeutics and interventions. So once you're able to identify the above, what do you do with this child? So the practical change objectives are appropriately prescribe oxygen therapy for pediatric patients and implement appropriate therapeutic options for pediatric patients with hypoxia. So our main focus we always start with the basics of air. And these are the 4 things I don't want you to forget. First thing is to open the airways. Always ensure that the airway is patent. That is the first rule. Patency can be, as we'll show you later on, how to maneuver the position at which the patient is sleeping. Just a small maneuver of the head and putting the child in a sniffing position. Things like suctioning, what you can see, can also clear the airway and just improve oxygenation. Then pulse oximetry and oxygen therapy, if indicated, is another thing, and also suction as needed and ECG monitoring if indicated. So we have some the case update. Let's just scroll down. So our patient, as we noted earlier, had hypotension. Maybe let's scroll down. So had hypotension, had fever. So what the interventions that are given so far is they have done a bolus of 20 mils per kg of normal saline, empiric IV antibiotics, and paracetamol. Our vitals, temperature still high, but has reduced to 38.4. Pulse rate is 125, has reduced a bit. Respirate still high at 32. BP has slightly improved to 81/42. And our saturations are 90% on 4 liters on cannula. So physical exam, it's unchanged, the exception of now our mucous membranes are a bit moist. So the classic clinical presentation for upper airway obstruction, like you've seen even in the video, is a stridor. It's a high-pitched noise during inspiration. And so I would like to ask, what are some of the etiologies that can give you upper airway obstruction? So what are some of the things that can give you a stridor? So maybe I just give you a minute to write some of the answers in the chat box. What can give you a stridor? Yes, thank you. Foreign body. Anything else in a child that can give you? Yes, epiglottitis, acute respiratory distress, true. Oh yes, then thank you. Viral croup, which is very common, and the foreign body. These two are the most common you'll find. Okay. Severe respiratory distress. Okay. Okay. So maybe we can click and then we can see some more options. So the main thing is the pediatric airway is already very narrow. So anything that can compromise that, the air is already very narrow. So just even something very slight, like even just an inflammation, simple inflammation can just cause the child to start having a stridor. So a CRU is one of them. It's typical mainly for influenza, parainfluenza, and then it has a characteristic barking cough, which will lead to upper airway edema. Then you can get subglottic stenosis, so like patients who have a prolonged intubation, or even patients who put a tracheostomy on, they scar formation, they end up having this. Also anaphylactic allergic reactions, something that is also very common in children. So that is something also to always anticipate. Tracheomalacia, when there's weakening of the cartilage, leading to floppiness, laryngomalacia, vocal cord paralysis. There is epiglottitis, someone mentioned that. You can have the laryngeal polypomatosis, especially if the mother had HB. Then children can also develop laryngeal tumors or hemangiomas, laryngeal webs, vascular impingement of the trachea. There's caustic ingestion. This caustic ingestion, something that is very common is when children have toys that have batteries, the small watch batteries, children tend to swallow that a lot. And by the time you retrieve, the corrosion actually occurs all the way from the esophagus to the trachea. That is a very common thing that causes tracheoesophageal fistulas, and then they end up now with these problems. So, and that was very common in Kenyatta. Burns injury, there is angioedema, foreign body aspiration, sedation, sleep, suffocation, effect leading to poor upper airway. So those are, at least you have very many options, okay? So which of the following interventions are effective in relieving upper airway obstruction? Which of the following interventions are effective in relieving upper airway obstruction? I think we can do a poll with that. Is it possible? Yes. Let's do a poll. So which interventions are effective in relieving? Is it the positioning of neck, nebulization with epinephrine, steroids, Helmick maneuver for foreign body, suctioning of secretion, all of the above? Mm-hmm. Thank you. A few more seconds, I see, just good. Okay. Yes, thank you. Maybe let me a few more seconds. Can see at least 16 people have responded. Okay, maybe we can end the poll. That's okay. So most of you have correctly indicated all of the above are what we use to relieve upper airway obstruction. So nebulization with epinephrine for CRU, this is a very common thing we do, especially for those children we said, mostly when they present with that barking cough and the stridor. So that is one of the interventions we do. We give steroids, epiglottitis, so it reduces and the inflammation, therefore just the airway becomes more patent. The Helmick's maneuver for foreign body, I think most of you are familiar with it. the patient, hold them from behind, put like more near the abdomen, you put pressure, and then to be able to expel the foreign body. Also suctioning of secretions is also very, at times you just find that is the only thing that actually is making the patient have a stridor, especially post-op. So all of them are true. Okay, let's continue. Okay. So this typically is trying to show you, maybe you can go through it in your own time, just showing you the way the anatomy of a child is so narrow and why you need to be very vigilant with children. So as I had alluded to, there is something, an infant in sniffing position. When we were talking about patency of the airway, one of the maneuvers is to the positioning of the child. So when you look at this child, the first thing is the chin. There's a way you hold the child at the chin, you just lift the chin. So it's called a sniffing position. So what this does, it opens up the neck, and even it's like prevents the tongue also from falling back. So you can see now there is a horizontal alignment of the auditory meatus to the suprasternal notch. Be careful not to overextend the neck. The best way is to put a shoulder roll behind lift the baby just below the shoulders. You put a small shoulder roll, and then you put a headrest. Then in that way, you open up the airway, so it is patent. So the classic description of clinical presentation, so that was upper airway obstruction. So now we'll just do a brief lower airway obstruction. So the classic description of clinical presentation of lower airway obstruction is wheezing. Upper airway is a stridor. Lower is wheezing. And the most common etiologies are asthma and bronchiolitis. So small question, which of the following interventions should not be utilized to relieve lower airway obstruction? We can do the poll quickly. Okay. Maybe a few more seconds if there's someone else. Okay. I can see a few people answering. Okay, maybe we can close the poll. The correct answer is A, which most of the people have gotten. So we're not saying that you overload this child, but you'll fluids, but don't rest, like most of it, like when we are doing ARDS, we are being very strict with our fluid intake. So these children, you do not restrict, because some of them will actually come in shock. So you will not restrict the fluids as much as in a child who has ARDS. Bronchodilators is basically what you use in asthma, where bronchodilators will be like your normal salbutamol, albuterol. Those are the things you use. Corticosteroids are given, and at times we even give, actually most of the recommended, right, what we recommend, especially for asthmatic patients, is you will give, yes, the short-term bronchodilator, something like Ventolin, but you'll also add a corticosteroid like which is long acting, that will help the patient that they don't even, which reduces the inflammation, which in subsequently will reduce the number of asthmatic attacks that the child gets. Also, subcutaneous epinephrine is actually given. So what else? Something that also may not be there, magnesium sulfate is also something that is also given for lower airway obstruction. So, the other question is, list 3 treatment guidelines to alleviate the work of breathing. So you list treatment guidelines to alleviate the disorders of breathing. Maybe just click. Yes. So the 4 things that we initially started with, main thing, positioning. If you do not have a good positioning, the airway may just be obstructed. So make the airway patent. Yeah. So depending on what you have, the presentation you have, if you have the stripe, so you know it's upper airway obstruction. So you need to intervene. If it's CRU, you need to give epinephrine, you nebulize, and corticosteroids. Anaphylaxis, you need to give epinephrine, albuterol, antihistamines, corticosteroids. For foreign body, clear the airway. If it's something that you can see, you can pick it. If you can't see, don't touch, because you may push it even further. Then if the patient is able to breathe despite now the foreign body, take the patient to the child mainly to hospital for an ENT review. For lower airway obstruction, we've already done this. We said we have albuterol, ipratropium, corticosteroids, subcutaneous epinephrine, magnesium sulfate, and terbutaline. For bronchiolitis, you have to do nasal suctioning and bronchodilators as well. This part, it actually shows just like the disorders of breathing. So like when you have increased intracranial pressure, what you should do is avoid hypoxia, avoid hypercarbia, and avoid hyperthermia. So in essence, you just make sure the patient is well oxygenated. They're being able to blow out their carbon dioxide. You don't want them to have a high level of carbon dioxide, because it will cause the brain, it will cause the more blood flow, and then the brain, there will be swelling, more swelling, there will be more edema. Then the patient needs to be at normal temperature, normothermia. So you can have neuromuscular support, ventilatory support if applicable. Overdose or poisoning, so you identify the appropriate antidotes for this patient, and you contact the poison control for specific treatment if you cannot actually identify what to give the patient. For lung tissue disorder like pulmonary edema, these are patients who have, as Dr. Rachael had said, there's water in the alveoli. So if these patients, you need to consider ventilatory support, you need to give PEEP. When you give PEEP, you're giving pressure to the alveoli. So in that way, you're able to push water out of the alveoli, and then you increase the surface area for oxygen delivery, for gaseous exchange. So there is vasoactive support, and diuretics are also, so that you're able to diurese more water. For pneumonia, albuterol, antibiotics as indicated, and CPAP if needed. So I think this chart will be sent to you. It's a very small but very nice chart for you to know how to manage patients. Okay. Okay, I think we've already done that. We've already gone through that, so it's fine. So a case update. So the patient was given another bolus, 20 mils per kg of normal saline, dopamine at 5 mics per kg per minute because the pressure was still low, and the child was started on high flow on cannula at 10 liters per minute, FiO2 of 60%. Vitals, slight reduction in temperature, 38.3. Pulse has reduced to 120. Respirate has gone down to 24. BP has slightly increased, and our saturation has increased to 95%. Physical examination, there's bilateral conjunctivitis, no discharge or scleral icterus, mild periorbital edema without erythema, slightly swollen, strawberry red tongue, mild intercostal retraction, but resolution of suprasternal retraction, wheezing noted bilaterally with crackles at bilateral lung bases, no stridor, no rubs, good air entry. PMI in the left anterior axillary line in the 6th intercostal space, tachycardia with regular rhythm. Normal S1, S2 with an S3 gallop, hard, and no murmur, no rubs. Pulses, +2 pulses in the extremities, strong femoral pulses. Initially, they were weak femoral pulses. Cup refill is less than 2 seconds, so it means we have improved. Initially, it was greater than 3 seconds. So given this picture, the diagnosis of the child, as alluded to, is we are going to add on to the things that we had already discussed. This child has issues in most of the systems. So now this becomes a multi-system inflammatory syndrome in children, MISC. So the diagnostic criteria is individuals aged less than 21 years, presenting with fever like this child, lab evidence of inflammation, evidence of clinically severe illness requiring hospitalization with multiple systems, more than 2 organs involved, cardiac, renal, respiratory, hematologic, gastrointestinal, dermatology. This child actually had criteria, had cardiac, had respiratory, had an enlarged liver, had I think some rashes. So this child, and even neurologically, the child was lethargic, was drowsy. So this child meets this criteria. No alternative plausible diagnosis.
Dr. Rachel, I think Dr. Eunice got cut out. The network. Are you able to?
Yeah. Maybe if I'm being hurt, I don't know what happened. Anna, can you hear me?
It's a little bit clear. You have a lot of feedback in the background.
What about now?
Okay, yeah, that's better.
We can give Eunice a minute. Just 1 minute. right, I think I can continue. She had completed this slide, so I think we can go down. So this is just any additional resources that are available, and you can get about more information on the criteria of COVID and even COVID-19. By now we should be experts on this. So we have come to the end of our presentation today, and we'll close with the Chinese proverb. If you're planning for a year, sow rice. If you're planning for a decade, plant trees. If you're planning for a lifetime, educate people. So I don't know if there's anyone with a question before we wind up, or clarification that needs to be made. Okay, I guess there's no one. So I want to come to the end of this session. Thank you so much for your participation and for your availability during these sessions. It's our prayer and hope that at least we've been able to communicate and give you information or add some information or knowledge to you. We thank you so much. Thank you, Alana, Assist International. Thank you, ECHO, for putting this together. Thank you, Stanford University as well for bringing it up. So for those, in case there's anyone who's new, we usually have these sessions the first Friday of every month. So the next one will be next month, March. So we'll be heading to session 9. We're almost coming to an end. There are 12 sessions. And we welcome everyone to join us in the next session, which will be session 9. And thank you so much for attending. Have a lovely evening. I don't know if Alana has anything to say. I can hand it over to her. Alana.
Nope, nothing specific to add. Just thank you to all the participants who joined in today, and encourage you that if you have questions about the material between sessions, WhatsApp group to ask questions or to get advice. So we encourage you to do that as needed. And to join the WhatsApp group, you can scan the QR code that's on the screen, or you can message me at the number shown on the screen as well. And then my final note is that if you would like to review the materials discussed today, everything is posted on the Learning Resource Center. I will share the link to that in the chat in just a moment. The Learning Resource Center contains all of the modules, all of the resources, plus additional tools, quizzes, exercises, and videos that you might find useful as you refresh on the material. Thank you.
Thank you, everyone. Have a lovely evening and a lovely weekend. Okay, bye-bye.